Warda. I'm from Lebanon. I'm a speech and voice pathologist. I've been in the clinical practice for more than 10 years now, and I have worked with professional voice users as well as children with other kinds of um, oral oral problems, articulation, language delays, etc. And today I will be talking about the importance of the collaboration between ENT experts and speech and voice pathologists. I am also a voice therapy professor at Phoenicia University in Lebanon. So today we are talking about a topic that is very important, that is the multidisciplinary approach in diagnosing and treating voice disorders. So it's not only about doing therapy after surgery, but it's also related to pre-surgical voice therapy in order to prepare the patient for the correct voice production and everything related to the surgery, the procedure, and the recovery phase. So, what is the voice? It is more than just a sound. It is related to a person's identity because your voice is unique and it is impossible for two people to have the same voice. So it's like a fingerprint. So it is a complex, finely tuned function of the human body. And we do all know that producing voice requires the air going out from the lungs and hitting the vocal cords in order to create vibration on the vocal cords. And then the voice will be shaped by the articulators inside the mouth through the teeth and the tongue for oral and speech expression. But beyond its physical component, the voice is how we connect with the world. So we are able to express our thoughts, emotions, authority, comfort, and identity through our voices. We use our voice to teach, to negotiate, to sing, to pray, to care, to entertain, to do presentations like today, and in many cases to earn a living. So, why does it matter? For our patients, especially professional voice users, a voice disorder is more than just a medical condition. It can be personal, emotional, and even a financial crisis for a person who uses their voice to make a living. Even for non-professionals, the inability to speak clearly or comfortably can lead to social withdrawal, to anxiety and frustration. And this is why understanding and protecting vocal function is not a luxury, but it's a must. It's a necessity. And it's exactly why ENT specialists and speech therapists must work together in order to increase and optimize the chances of a better result and recovery for the voice. So, as we just said, that the voice is unique, it is like your fingerprint. It is shaped by anatomy, by physiology, and the habits of each individual. Its production requires precise coordination between breathing, phonation, resonance, and articulation. And this intricate harmony makes the voice not only a tool, but a personal living instrument. So it is the instrument that we all play every single day. So, why the multidisciplinary approach? Voice disorders rarely have one cause. The cause is, excuse me, it's funny speaking about the voice. They are multifactorial and the causes overlay. They involve anatomical, functional, emotional, and behavioral components. While you, as ENT surgeons, can identify and treat structural issues, speech and voice therapists uncover the behavioral patterns that the patient is doing that are causing or exacerbating these issues. Let's talk about a certain case, a patient with bilateral vocal fold nodules. The pathology is clear, but what is leading to this pathology is not always clear, especially to ENT specialists. The excessive vocal loading, the poor breath support, the hyperfunction, these habits that have developed over time. Surgical intervention can be good and is necessary to remove the nodules, but without training the voice and regaining a healthy voice behavior, the pathology will most likely return. So, in a lot of cases, removing nodules is not the cure for the problem. Excessive vocal load and insufficient voice use can lead to microlesions that are repetitive, and it causes phonotrauma to the vocal folds. With ongoing overuse, the tissue enters a cycle of incomplete healing, and it surpasses the capacity of the body to heal the vocal cords because the patient is being overloaded, is lacking sleep, is not preserving and keeping a good vocal hygiene. So it surpasses the capacity of the body to heal the vocal cords on a daily basis. When this stress becomes frequent and excessive, it exceeds the natural capacity of the tissue to heal. And this repetitive trauma without proper behavioral modification results in chronic vocal fold pathology and a high rate of reoccurrence post surgery. In our approach, we advocate for voice therapy not only after surgery but also before the surgery to ensure long term results. Pre surgical therapy helps reduce inflammation, improve vocal efficiency, and even delay or avoid surgery. Post surgical therapy ensures healthy phonation, prevents compensatory habits, and supports full functional recovery. Another key element in our partnership is understanding the difference between functional and structural voice disorders. So, functional dysphonia is related to poor use, but the anatomy is normal. Nothing is shown in video stroboscopy on the vocal cords. In contrast, structural issues include nodules, polyps, cysts, and even vocal fold paralysis. But the line is not always clear between the two. Sometimes what presents as a minor lesion turns out to be secondary to functional misuse. That's where our assessment tools come in, like the perceptual analysis, the acoustic measurements, and even aerodynamic evaluations give us a broader picture. One of the key studies in this area is by White in 2023, which explores the impact of pre and post operative voice therapy for patients with benign vocal fold lesions. The study emphasizes that preoperative therapy serves to identify and manage underlying factors contributing to vocal lesions while also preparing the patient for surgery and improving their readiness for recovery. This therapy helps address the causative factors and allows patients to better understand the expectations from the procedure. Following surgery, post-operative voice therapy plays a crucial role in promoting wound healing, improving the vibratory characteristics of the vocal folds, and ensuring proper recovery. This intervention reduces the risk of complications and reoccurrence of lesions. The study highlights that combining both pre and post operative therapy provides a holistic approach which not only supports physical healing but also optimizes functional recovery and ultimately leading to improved voice quality and reducing the risk of future trauma. Regarding the voice screening that is done by the voice therapist, it is a brief and targeted evaluation, and it includes gathering a concise case history, the onset, the symptoms, the vocal demands, and information about the patient, the lifestyle, the profession, and occupation, and then performing a perceptual voice analysis. We need to analyze the quality of the voice, the pitch, the loudness, the resonance to the ear of the voice therapist, and then conducting a basic acoustic and aerodynamic observation by using the tools analysis like analyzing the jitter and shimmer of the voice, as well as um, the fundamental frequency of the voice of the patient. We use it as a baseline to understand the state of the patient, the current state of the patient's voice, and it could be used as a pre and post evaluation to measure progress throughout the therapy. Referring to an ENT specialist when structural concerns are suspected. Screening guides screening guides next steps in diagnosis and ensures timely, appropriate care. Pre and post therapy evaluations are very essential, as we said, to document voice outcomes, to measure progress, and adapt therapy goals. Therapy in functional cases may be all the patient needs. In structural cases, it plays a complementary and preparatory role. I've worked with patients who underwent surgery without prior therapy and return weeks later with worsened tension patterns or reduced vocal flexibility. One case is a patient who had a vocal nodule and it was extracted by an ENT surgeon, and he was not able to recover for a long time, even after removing the nodules, and it took several months of voice therapy until the patient was able to recover. Contrast that with patients who began therapy beforehand. They often regain optimal voice function faster and more confidently after surgery because they are prepared and they have trained their breathing, the relaxation of their muscles, the correct use of their voice, the positioning of their voice has become better. And now let's talk about professional voice users, a very special population who come seeking voice therapy, like singers, teachers, public speakers, religious leaders, and lawyers. These individuals depend on their voices not just for communication, but also for livelihood and identity. And they often wait too long before seeking help. And when they do, it's usually with significant strain, fatigue, or even acute injury. Surgical treatment alone isn't enough. These individuals need targeted voice training and therapy that respects their vocal demands and artistic goals. There was one case who is a soprano singer who came to us after microlaryngeal surgery. Her voice returned technically, but she had lost her resonance, her stamina, her pitch control. She lost her high notes. Through structured voice rehabilitation, we worked on the breath support, the semi-occluded vocal tract exercises, the resonance balancing, and there was a gradual return to performance. Within weeks, she was back on stage, and more importantly, she was confident in her voice again. The axes of intervention are carefully selected based on the specific needs of each patient, taking into account the severity of the condition, their vocal demands, and individual challenges. This ensures a personalized approach that addresses the underlying causes of voice disorders and supports the patient's recovery effectively. So also posture adjustment. I consider it very important to emphasize on the alignment of the body in order to promote and optimize the vocal fold function. It could be harmful for a person with bad posture to be able to project their voices, especially with a posture that closes the area of the neck and makes it and gives the throat uh, um, a little space for it to vibrate or move with ease while the person is speaking. Correct spine is crucial. Correct head and neck positioning are very important. The other axes, resonance, articulation, and manual therapy. Articulation is equally very important for the person to learn how to position their tongue, to work on jaw mobility, to work on the articulators and articulation points that help in better projection of the voice. Instead of having a pharyngeal voice that is vibrating inside the throat and pharynx, it is important to position the voice and to grow sensations and intuitions about the voice that are more to the anterior part of the face, to the anterior part of the oral cavity. We focus on the lips. We focus on the vibration being heard in other part of the oral cavity. Another axe is manual therapy. That is not very common, but it is a myofascial release and soft tissue manipulation for muscle relaxation. And this technique is becoming more and more important, and we're becoming more aware of it, especially in treating muscle tension dysphonia when no lesions are shown on video stroboscopy on the vocal folds, but in contrast, we can see that the patient is straining. We could see the contractions of the muscles around the neck, around the larynx that are being over contracted in the moment of speech. So we use this technique to help the patient be aware on the tensions, contractions in the cervical area and the neck area in order to release this tension and bring the patient to be more aware on these muscles in his body. So our job is not just to heal the vocal folds, it's to restore the person's connection to their voice. It is to re-establish the person's vocal identity and emotional and functional healing. And what I hope that you'll take from all this, that speech therapy is not an afterthought, it is a necessity and a core part of the healing journey. And by collaborating early enough, especially before surgery, we can prepare the vocal mechanism and optimize the conditions and sometimes even avoid surgery. Now, I don't know if ENT surgeons would be mad at us, but it is possible to avoid surgery in the vocal cords when we do proper therapy before deciding on these procedures. And after surgery, we are essential in ensuring full functional recovery, reducing the risk of reoccurrence, and empowering patients to use their voice safely and sustainably. So I suggest that we collaborate even more. ENT is referring to voice therapists and vice versa in order to optimize the recovery of our patients. So together we can do more than just treat pathology. We can restore the identity, the function, and the confidence of the people who trust us with their voices. Thank you.
Hemorrhagic telangiectasia. Hereditary hemorrhagic telangiectasia, also referred to as Osler-Weber-Rendu syndrome, is an autosomal dominant disease leads to the formation of abnormal communication between arteries and veins, with a resultant spectrum of vascular anomalies. The prevalence of HHT varies between 1.5 to 2 in 5,000 to 10,000 persons worldwide, depending on the geographic area. Is quite higher given that the signs of HHT may go unrecognized, undiagnosed, and untreated for decades or cause premature death. Severity of epistaxis increases with age. More than half of patients will develop troublesome epistaxis by the third decade of life. Several gene mutations have been associated with HHT, allowing for focused genetic testing. The majority of cases involve mutation on two genes. Type 1 involves the ENT gene on chromosome 9 encoding endoglin. Type 2 involves the ACVRL1 ALK1 gene on chromosome 9 encoding activin A receptor-like kinase. A mutation of the SMAD4 gene on chromosome 18 is associated with a combination syndrome involving both juvenile polyposis and HHT. The three gene mutations encode proteins that modulate TGF-beta superfamily signaling pathway involved in angiogenesis. Modulated TGF-beta transmits signals to vascular endothelial cells, cause an inadequate response to angiogenic stimuli in specific locations, leading to remodeling of the vascular endothelium and to loss of elasticity and dilation of arterial-venous communications. As a result, fragile and thin-walled telangiectasias form within the nasal cavity in regions with high airflow prone to dryness or repeated mechanical trauma. Thus, the discontinuity of the vascular walls at the sites of dysplasia and not the blunt coagulation disorders is what causes the bleeding in patients with HHT. Clinical diagnosis of HHT is based on the presence of the Curacao criteria established in 1999, which remains widely used today. Mutation in genes were identified in approximately 75% of individuals who met criteria for clinical diagnosis of HHT, confirming good concordance of mutation and disease occurrence. Once a family member has been diagnosed with HHT, subsequent relatives only need to be tested for that. Distinct phenotypic variations. Patients with HHT1 are more likely to present with epistaxis earlier in life as well as pulmonary AVMS. Patients with HHT2 are more likely to develop hepatic AVMS. HHT is a progressively evolving disease characterized by a wide range of symptoms which show a correlation with age, affected organ type, and extent of the attack. The characteristic clinical findings in HHT are epistaxis, telangiectasias, and arteriovenous malformation AVMS of visceral organs and central nervous system. ENT manifestation and examination findings in HHT, recurrent spontaneous epistaxis, sequel of recurrent epistaxis or prior treatment such as crusting, full odor, nasal obstruction, septal perforation. In addition to the nasal cavity, mucosal telangiectasias can involve the lips, hard palate, tongue. Multiple cutaneous telangiectasias are commonly seen on the skin of the face, ears, and fingertips. In a patient presenting with intranasal telangiectasias without a prior diagnosis of HHT should be differential diagnosis from CREST syndrome, essential telangiectasia, and ataxia telangiectasia syndrome. Iron deficiency in conjunction with low ferritin and elevated transferrin is characteristic in patients with moderate to severe epistaxis. Initial evaluation and management in HHT. Anterior rhinoscopy and nasal endoscopy performed atraumatically with careful removal of any eschar or blunt clots to assess the number, size, and morphology of telangiectasias. Intranasal crusting and blunt clots are typically present overlying large telangiectasias, and debridement, if indicated, should be performed carefully to prevent bleeding. Nasal crusting is particularly prevalent in patients with a history of septodermoplasty. Cotton ball socket with oxymetazoline or equivalent topical decongestant are useful adjuncts during the examination. Nasal endoscopy is useful to evaluate for septal perforation, scarring, and more posterior telangiectasias that may not be evident on anterior rhinoscopy. There are three distinct vessel types associated with nasal telangiectasias in HHT: small punctate isolated telangiectasias type 1, which are associated with mild epistaxis; diffuse lesion associated with feeder vessels type 2; and large isolated IVMS type 3, which are associated with moderate or severe epistaxis. Morphological characterization and quantification of the number of lesions may be useful for treatment planning. For example, smaller type 1 lesions tend to respond well to KTP laser treatment, while large type 2 MT3 lesions are better treated with electrocautery and completion. Epistaxis severity score. Validated scoring tool used to quantify epistaxis severity. ESS can serve as clinical and therapeutic outcome measure for epistaxis in HHT. 6 factors are independent predictors of self-described epistaxis severity, such intensity, frequency, duration, need for medical attention, transfusion related to epistaxis, anemia. 6 questions are answered. The number of responses is multiplied by the respective coefficient, and the sum of these gives the raw epistaxis severity score. Severity of HHT-related epistaxis ranges from mild occasional nasal bleeding to severe life-threatening epistaxis. Expert guidelines recommend annual hemoglobin and hematocrit screening in patients older than 35 years. Before surgical intervention, a complete blood count with type and screen or type and cross-match. Patients should be questioned regarding the need for recent blood transfusions. According to the second international guidelines for the diagnosis and management of HHT, screening examination for pulmonary and cerebrovascular AVMS are recommended in all patients with HHT at time of diagnosis. Bubble echocardiogram every 5 to 10 years to rule out formation of new AVMS. Routine GI endoscopy is not indicated. Only patients with a history of GI bleeding and/or anemia and disproportionate to epistaxis severity. Treatment of ENT manifestation of HHT is supportive. No standard treatment algorithm is available. However, a ground-weighted treatment strategy beginning with conservative topical therapies progressing to more invasive surgical treatments is recommended. Non-pharmacological preventive measures, proper nasal hygiene, avoidance of triggers and anticoagulants if possible. Humidifying agents can maintain integrity of the nasal mucosa. They prevent nasal crusting and reduce damage to the endonasal mucosa, leading to a reduction of epistaxis. Nasal ointments usually contain lanolin, dexpathenol, or saline. For acute management of bleeding, the only conservative strategy that can be employed is nasal packing. Unlike coagulation methods, in nasal packing there is no risk of septal perforation. The main disadvantage is that its removal can cause rebleeding. Topical medical treatments include bevacizumab, estriol, tranexamic acid, thalidomide, and timolol. All groups have a significant improvement in epistaxis severity score. However, there were no statistically significant differences between them regarding the factors such as frequency, duration, and severity of epistaxis, hemoglobin and ferritin level, need for transfusion, emergency department visit, and treatment failure. Bevacizumab is a monoclonal antibody inhibitor. When used topically, benefits of treatment generally extend for 2 weeks following cessation of use. High risk of septal perforation in submucosal injection. Pharmacological therapies include antifibrinolytics, reinforcing coagulation by inhibiting fibrinolysis associated with telangiectasias. Tranexamic acid is a strong antifibrinolytic agent that, according to the multinational ATAR study, significantly reduces the duration of epistaxis. However, it is contraindicated in patients prone to thrombosis. Hormonal therapy, estrogens, and in particular raloxifene and bazendoxifene, are transcriptional activator of the ENG and ACVRL1 ALK1 gene promoter that cause a significant reduction in epistaxis frequency and quantity, as well as an improvement in the hemoglobin levels. Immunosuppressor tacrolimus is very effective in increasing the expression of ENG and ALK1, reducing epistaxis, anemia, and telangiectasias. Nonetheless, continuous use of FK506 is not recommended due to its suppressor effect on the immune system. Atorvastatin increases the expression of endoglin and the ENOS protein, thus improving epistaxis. However, should be considered secondary effects of statins. Pharmacological therapies include antiangiogenic drugs, reduce the excess abnormal vasculature present on the nasal mucosa. Bevacizumab has been shown to be beneficial in the treatment of HHT patients with severe hepatic AVMS or severe gastrointestinal bleeding. Thalidomide suppresses level of the angiogenic and growth factor and reduces epistaxis number and severity by stimulating vessel maturation through pericyte recruitment to vessel walls. The B blocker propranolol exhibits antiangiogenic and pro-apoptonic properties on endothelial cells, suggesting its topical use in HHT. Antioxidants NAC neutralize the harmful effects of ROS, causes a significant reduction in the frequency and severity of epistaxis, especially in male patients and HHD1 patients with ENG mutation. In this transparency, we can see the clinical recommendation from second international HHD guidelines of high relevance to hematologists. Available surgical intervention for HHD-related epistaxis. Monopolar electrocautery and silver nitrate cautery have been associated with increased risk of septal perforation and a tendency to worsen the severity of epistaxy, and therefore they are not recommended. Bipolar electrocautery and electrosurgical plasma coagulation are both effective surgical treatments for epistaxis related with HHT. Bipolar electrocautery is immediately effective in controlling epistaxis either as a standalone method or as an adjunct to KTP laser coagulation. Due to improved precision and decreased depth of thermal injury, it is preferred over monopolar electrocautery. It minimizes the risk of septal perforation. However, a faster return to the hospital with nasal bleeds was associated with use of bipolar cautery. The completion combines irrigating bipolar function along with completion function, which is useful for ablation or large conglomerate telangiectasia, is particularly effective during active bleeding. It is an acceptable alternative to KTP lasers. Laser photocoagulation. NDYAG KTP CO2 can destroy the defective blood vessels with minimal depth of thermal injury to the surrounding normal mucosa. It causes scarring and fibrosis, leading to a reduction in telangiectasias. Laser treatments are effective in reducing the duration, frequency, and severity of epistaxis in patients with HHT. The result is often time-limited and the procedure must be repeated. Not all flexible fiber devices can be used and maneuverability within the nasal cavities may be limited. Disadvantages of laser treatment include cost and lack of availability at some centers. Eye protection is required. NDYHG laser showed better results, especially for severe epistaxis as compared to argon lasers. Bilateral application carries the risk of septal perforation. Endoscopic intranasal minimally invasive surgical options, and in particular argon plasma coagulation, can be used as a first step even in patients with severe epistaxis and a history of blood transfusion. Less morbidity, reduced trauma of nasal mucosa, low risk of septal perforation, treatment repeatability, no need for post-surgical nasal packing, the possibility of local anesthesia, and short time of hospitalization are many advantages. The lower risk of perforation, the excellent results in tissue coagulation, and its easy execution make APC an alternative and safer method than the NDYAG laser. Endovascular embolization is mainly indicated in acute cases not responding to nasal packing. However, it carries a high risk of stroke and blindness. Sclerotherapy into defective vessels can cause scarring and fibrosis and reduce telangiectasias and therefore epistaxis. Significant improvements were found in epistaxis severity score and quality of life. Possible side effects of sclerotherapy are necrosis, cellulitis, anaphylaxis, pulmonary embolism, and permanent blindness. Disadvantages include reduced access to posterior lesion and reduced ability to control large volume bleeding. Cryotherapy causes perfusion disturbance with ischemia, temporary hemostasis, reepithelialization of the nasal mucosa, and a decrease in the frequency of chronic recurrent bleeding over time. Septal thermoplasty is recommended only as a last line of defenses. In this, the nasal mucosa is replaced by skin graft tissue or oral mucosa, while the underlying perichondrium is preserved. This technique does not allow control of epistaxis in situations where the bleeding originates from the lateral wall. The major complications are worsening of sinus infection, crusting, and decreased sense of smell. Therefore, this treatment is recommended in severe cases or in patients who had developed septal perforation after other treatments. Nasal closure of one or both nasal vestibule, also known as Young procedure, is used in patients with severe transfusion-dependent or life-threatening epistaxis or as last resort when other treatment options have failed. Significant side effects like chronic mouth bleeding, xerostomia, anosmia, and nasal voice which greatly affect the quality of life. Since its first description, various modifications of this procedure have been published in literature such as Land, MYP. Osler calendar, a care plan for HHD patients and their treating physicians. Its aim is to inform about the most common symptoms of HHD, to record their frequency and how to approach them, provides an overview of the necessary screening examination, documents their result, and reminds patients of the necessary follow-ups, records all therapeutic measures since last patient contact. Conclusions. HHD is complex disease with a multitude of clinical manifestations that require management and treatment by a multidisciplinary team. Despite the rarity of HHD, otolaryngologists must be aware of the general and ENT manifestation of this syndrome so that they can suspect disease from the initial stages, document the diagnosis with the help of other specialists, and treat with particular attention to recurrent epistaxis, which are the most common and dominant manifestation of HHD. Surgical intervention should generally be seen as a last resort, particularly when other medical treatments fail to yield results. The evidence suggests a preference for a conservative approach, preserving tissue and minimizing interventions. When surgery is deemed necessary, it should aim to address specific issues, such as treating larger or more problematic telangiectasias, and should proceed with utmost care to avoid damaging the nasal mucosa. Thank you very much. Incidence of oropharyngeal cancer is increasing, and human papillomavirus infection appears to be driving this change with little or no involvement of tobacco or alcohol. HPV-16 expression confer up to 231 times increased risk for OPC. The adjusted odds ratios for positivity to high-risk HPV infection in OPC was 20.3, confirming the strong association between HPV and HNSCC. The burden is higher for developed countries and for males, 4 to 5 higher incidence vs females. In the US, HPV DNA has been detected in 70.1% of OPCs. The incidence of HPV-positive OPCs increased by 225% from 1988 to 2004, while the incidence for HPV-negative OPCs declined by 50%. Exploratory objectives to record the physician choice for treatment strategy for all patients with OPC and by HPV status assessed by P16 expression and HPV DNA status and DNA stage. HPV-related oncogenesis defined both P16 and HPV DNA status in patients diagnosed with OPC. As a secondary analysis, HPV DNA genotyping. Attributable fraction of HPV-related OPC among OPC patients who were diagnosed over a 6-year period and who have had available treatment-naive cancer tissue. Descriptive statistic of each treatment strategy were provided overall and by HPV status and tumor stage according to TNM8 classification. HPV-positive patients were defined as those with a combined positivity for P16 expression and HPV DNA presence. Central laboratory analysis of HPV status included P16 and PCR for HPV DNA status. OPC staging diagnosis was based on TNM8 classification. Newly diagnosed patients defined as those diagnosed with OPC up to 2 months before enrollment. The attributable factor of HPV-positive OPCs was estimated by dividing the number of patients with HPV DNA positive P16 positive by the total number of patients with available HPV status. This study included 147 eligible patients with OPC enrolled at 8 study sites. Results of our FAIR study. In total, 147 patients, 144 of all were with available HPV status. HPV attributable fraction for all patients with available HPV status was 52.1%. HPV attributable fraction, excluding patients with discordant results between medical records and central lab, was 55.2%. HPV attributable fraction, excluding patients with discordant result between HPV DNA and P16 expression, was 16.5%. Exploratory objectives to record the physician choice for treatment strategy for all patients with OPC and by HPV status assessed by P16 expression and HPV DNA status and DNA stage. HPV-related oncogenesis defined both P16 and HPV DNA status in patients diagnosed with OPC. As a secondary analysis, HPV DNA genotyping. Attributable fraction of HPV-related OPC among OPC patients who were diagnosed over a 6-year period and who have had available treatment-naive cancer tissue. Descriptive statistic of each treatment strategy were provided overall and by HPV status and tumor stage according to TNM8 classification. HPV-positive patients were defined as those with a combined positivity for P16 expression and HPV DNA presence. Central laboratory analysis of HPV status included P16 and PCR for HPV DNA status. OPC staging diagnosis was both based on TNM8 classification. Newly diagnosed patients defined as those diagnosed with OPC up to 2 months before enrollment. The attributable factor of HPV-positive OPCs was estimated by dividing the number of patients with HPV DNA positive P16 positive by the total number of patients with available HPV status. This study included 147 eligible patients with OPC enrolled at 8 study sites. Results of Orphea study. In total, 147 patients, 144 of all were with available HPV status. HPV attributable fraction for all patients with available HPV status was 52.1%. HPV attributable fraction, excluding patients with discordant results between medical records and central lab, was 55.2%. HPV attributable fraction, excluding patients with discordant result between HPV DNA and P16 expression, was 16.5%. The demographic and disease characteristics at OPC diagnosis. Overall, patients were middle-aged with a median age 16 years, predominantly male, 77.1%, male to female ratio 3.4 to 1. Similar numbers were either current or former smokers. The most frequently affected oropharyngeal sites were the tonsils, 48.6% at the base of the tongue. Of patients with available tumor staging data, most 39.1% were diagnosed with stage 4 disease. By HPV status, significant differences between groups were observed. HPV positive patients were younger. Regarding smoking, a lower proportion of HPV positive than HPV negative patients were current smokers. Conversely, a numerically higher proportion of HPV positive than HPV negative patients were never smokers. HPV positive patients consumed a lower median number of cigarettes per day and had a lower median number of pack years. A lower proportion of HPV positive than HPV negative patients were consuming alcohol. A higher proportion of HPV positive than HPV negative patients had tonsil tumors. Conversely, a lower proportion of HPV positive than HPV negative patients had tumors in the base of the tongue. Regarding OPC staging, 110 had available data. HPV positive 49.1% and HPV negative 50.9%. A higher proportion of HPV positive than HPV negative patients were in stage 1 and 2. The opposite was observed for patients in stage 4. Metastases were observed in 5.6% and 7.1% of HPV and positive and HPV negative patients, respectively. Newly diagnosed patients, defined as those diagnosed with OPC up to 2 months before enrollment, were 23.1%. The newly diagnosed patients were older than the rest of patients with OPC. Most patients were male. Regarding smoking, patients were former smokers. The most frequently affected oropharyngeal sites for the newly diagnosed patient were the base of the tongue and the tonsils. Of patients with available tumor staging data were diagnosed with stage for disease, metastases were observed in 7.1% patients who were incidentally HPV positive. About HPV genotyping, of the 75 patients with HPV positive OPC by central laboratory, most 93.3% were infected by HPV-16, either alone or in combination with other HPV types. 96% patients with HPV positive OPC were infected with high-risk HPV types, which are targeted by the HPV 9-valent vaccine. Most of the patients received radiotherapy, 90.4%, followed by chemotherapy, 81.6%, and surgery, 17.6%, alone or in combination. The most frequent combination treatment was chemotherapy and radiotherapy, followed by surgery and adjuvant radiotherapy. Regarding the individual agents prescribed, most patients treated with chemotherapy received platinum-based therapy. All patients treated with targeted therapy received cetuximab. Of patients treated with immunotherapy, 50% received nivolumab, 25% received atezolizumab, and 25% received pembrolizumab. 17.6% patients were planning to undergo surgery. Non-numerical differences were observed in the treatment choice by HPV status, and no statistically significant differences were observed in the treatment choice by TNM stage. The HPV attributable fraction found in Orphea study is substantially higher than previous studies in Greece. Possible reason for this difference is the variation in study designs and diagnostic algorithm used for HPV status determination and the difference in time periods. The incidence of HPV-associated OPC in Greece has increased over the years, currently surpassing those reported for Italy and approximating rates of several Northern European countries. The high HPV attributable fraction reported in Orphea study could be due to the patient selection process, the period under investigation, and the oropharyngeal anatomical subsite of tumor. Regarding the treatment modalities, our studies showed no significant difference between HPV positive and HPV negative patients with OPC, with the most frequent treatment combination being the chemotherapy plus radiotherapy given to almost 2/3 of patients. The treatment strategy may be diversified in the future. At present, adequate de-escalation strategies aimed at decreasing long-term treatment toxicities while maintaining the survival benefit with standard treatment have not been identified. Concerning genotype distribution, this study reported that HPV-16 was identified in almost all patients in agreement with the literature. The overwhelming majority, 96% of HPV-positive patients were infected with one or more of the high-risk HPV types targeted by the 9-valent vaccine. The increased HPV attributable fraction emphasized the need for public health intervention to mitigate the HPV-positive OPC burden. Conclusions. The Orphea study revealed that HPV attributable factor in OPC was 52.1% in Greece, exceeding the rates reported previously. HPV-16 was the most isolated HPV type. Compared with HPV-negative OPC patients, HPV-positive patients were younger, less frequently current smokers or alcohol consumers, had more frequently tonsillar tumor, less frequently base of the tongue wound tumor, less frequently disease stage 4. Based on the physician treatment choice, upon OPC diagnosis, most patients received radiotherapy and chemotherapy. No statistically significant association were observed between treatment choice and HPV status or TNM stage. Since the most of patients were infected by one or more HPV types targeted by the 9-valent prophylactic vaccine, the burden of HPV-positive OPC should be mitigated through the routine HPV vaccination program in Greece, and consideration could be given to extending a gender-neutral HPV vaccination campaign to older age groups. Thank you very much.
Better in rhinoplasty. So the thin-skinned nose can be identified by its often pale appearance and its inability to hide the nuances of underlying cartilaginous framework. Strong and thick nasal tip cartilage will compound the complexity of rhinoplasty in thin-skinned patients. Here, we can see two patients with all the characteristics that I told you. The skin is almost transparent, and you can see all the anatomy behind it. We need to keep in mind some precautions when we deal with thin-skinned patients. The skin has a tendency to contract and reveal underlying details, so it's important to dissect it in an adequate layer. The incision should be beveled and the transitions performed in a curvilinear fashion. The grafts must be thin and tapered, and the camouflage grafts are necessary. Here we have that patient that I have shown before, who I operated first in 2018 without taking these precautions. We can see all the grafts behind the skin with the edges marked, so after 2 years, we have so many irregularities in the nose. I took her again to the operation room, and now we see camouflage and with Now we use camouflage with platelet-rich fibrin and cartilage gel and made all the grafts again. Here is the result after 3 years, much better. Here we can see that on the right side, we are not in an adequate layer dissection with so much tissue along the cartilage. On the left side, it seems that we are on the adequate layer dissection, but we are not. It's not a superchondrial layer yet, like in this picture, which will allow us to draw in the cartilage without blurring it. The goal is to keep as many layers as possible above our dissection, but we need to consider the thickness and the fragility of our cartilage too, which can make us choose for a superperiochondral or even a subsmile dissection to keep its integrity and strength. This is the way I deal with the grafts, especially when we are using rib grafts. We need to take care about the thickness and the edges, trying to keep all the transitions smooth. It's important to keep always in our mind that during the post-operative healing, unpredictable scarring and contraction may occur and lead to a significant aesthetic and trophic sequelae. Besides a meticulous surgical technique, there are no reliable techniques to prevent skin damage and shrinkage. So talking about camouflage, when should we use it? When we deal with thin skin or poorly quality skin, when the surgery will involve large resections, or when we have little irregularities in the end of the surgery. In those cases where you are not in an adequate layer dissection, in revision rhinoplasty, and in my routine, I use it in almost all of my cases. We have some options to use as camouflage, such as diced cartilage or gel cartilage, temporal fascia, perichondral ligaments, platelet-rich plasma, or fibrin-rich plasma, and fat. It's possible to use associations between these options, but you need to keep in mind that some association will increase a little the final volume. I'm going to talk about the four first materials today. So the platelet-rich plasma is a platelet concentrate with growth factors. And this is the protocol that we have been using for the last 6 years. A venous blood sample is taken with anticoagulant, and then we centrifuge it at the speed for 10 minutes. After that, we aspirate the intermediate layer and add 1 ml of calcium gluconate. And again, we centrifuge it for 10 more minutes in the same speed. A platelet-rich fibrin has growth factors that accelerate the tissue healing, and in consequence, we will have less dead space and less edema. It improves the viability of the diced cartilage, and in patients with thin skin, we can expect a better aesthetic outcome with diced cartilage and platelet-rich fibrin. This meta-analysis about platelet-rich fibrin and diced cartilage was published last February and concluded that the addition of platelet-rich fibrin to diced cartilage in rhinoplasty was associated with favorable postoperative outcomes and high patient satisfaction. However, we don't have comparative studies with the use of diced cartilage isolated, so it's difficult to know if the platelet-rich fibrin provides more benefits than the diced cartilage alone. We have two options to use it, one liquid and one as a membrane. The protocol is very simple. A blood sample is taken without anticoagulant, 14 ml in its tube to avoid overflow, which are immediately centrifuged at 4,000 RPM for 20 minutes. It's important to leave in the same place for 30 minutes after the centrifugation has finished. Sometimes we can put a graft inside the platelet-rich fibrin, like a sandwich, to decrease the reabsorption of the graft and keep the transitions smooth. In this case, I did it on the radix. An option is use it for covering the gel or free diced cartilage. So again, we have less reabsorption and a little increase in the final volume. And the position of the cartilage will be easily sustained. You can use it alone to recover some grafts or the tip sutures. It helps to keep the dorsal smooth and regular for good. Here we have an example of the liquid platelet-rich fibrin used as a stick graft with free diced cartilage. We used it to increase the dorsum and cover all with a membrane of platelet-rich fibrin. Here is the table result of this patient. It was a secondary rhinoplasty. I did an endonasal approach only to correct the dorsum. In the fishbone technique, which we described in these papers a few years ago, we can use the platelet-rich fibrin to avoid irregularities, even though in the original paper we did not point it out. I use it always to cover these fractures. Here we have the result of this patient on table. It was a crooked and large nose. And a couple of weeks later, she sent me a video to ask me some questions, and we can see how beautiful the aesthetic lines are, even with only 2 weeks. Now talking about fat, we can collect the fat through liposuction, and then we can handle it with this device, the traditional fat transfer or the lipocube. The lipocube is faster, also on passages enough, but we cannot reuse it. So we have an increase in cost, but it's a good option too. We can use the fat as a filler to correct small defects in the nose or in the rhinoplasty. The fat can be changed into macrofat, microfat, or nanofat, depending on the purpose. We have evidence of the benefits of using fat transfer, as you can see in this paper. It can be used isolated or in addition to platelet-rich fibrin, fascia, or perichondria. The first study is about the macrofat with platelet-rich fibrin showing good results. The second one tells us to use microfat to increase the volume and nanofat to camouflage in fascia or perichondria. And the last two ones present a better viability of the free diet when we use it with fat. In this paper, they use fat from liposuction and only cut it up and cover with a membrane of platelet-rich fibrin. I'd rather use microfat instead, as you can see in this video. This is the way I use fat and platelet-rich fibrin. Here we have a secondary rhinoplasty with rib cartilage. We took the fat from the thoracic region near the rib while we were collecting the rib. Then we processed it into microfat and use it at the end of the surgery to make the dorsum smooth and with no irregularities, providing more quality for the skin too. The membrane helps to keep the fat in the place where we put it. After that, I improved the grafts of the tip and cover with platelet-rich fibrin too. Here we have a recent meta-analysis that shows us the level of evidence of the papers that discussed the nasal camouflage. In this level 2 evidence study, we can see that the cartilage gel plus platelet-rich fibrin resulted in better long-term aesthetic outcomes comparing with diced cartilage. In this level 1 evidence study, the patients with diced cartilage showed a higher level of satisfaction comparing to lipofilling, temporal fascia, or no camouflage. And in another level 4 evidence study, the lipo injection of microfat grafts had good satisfaction scores. And the last study is another level 4 evidence 1, and we can see that autologous fat with platelet-rich fibrin improved the skin quality and concealed irregularities. Now I'm going to show you some cases. So here is a 1-year post-operative of a structural rhinoplasty with split spreader flats, a technique from Renato Souza from Brazil. And even though she has thick skin, I used camouflage on the dorsum with gel plus platelet-rich fibrin because it was a large resection. Here we have the basal view, helicopter view, 3/4 view, profile, and smile. And I used a tachograph to support the teeth. And because she has thick skin and weak cartilage, I am not on the subperichondrial layer. To give this cartilage more strength, I put camouflage on the tip with the ligaments. Here is a 1-year post-operative of a spare roof A technique with a structured tip. We used platelet-rich fibrin plus cartilage gel to camouflage the transition between the cartilage and the bone. And here we have the results. Here is a 1-year post-operative patient of a primary rhinoplasty, a preservation rhinoplasty, and I used camouflage on the radix with a thin solid graft involved with platelet-rich fibrin, avoiding a step to be taken. Here, 3/4 view, profile is mine. Here is a 2-year post-operative of a patient with primary rhinoplasty, preservation rhinoplasty again. And again, I use camouflage on the radix with a solid graft involved with platelet-rich fibrin, avoiding that step. Here's a 2-year post-operative of preservation rhinoplasty, spar B, crooked nose with thin skin. I used platelet-rich fibrin to cover all the fractures. This is a patient that had a previous rhinoplasty. It was a completely twisted tip in a thin skin. We can see the aspect of the alar cartilage when I open the nose. And here is the aspect of at the end of the surgery, with the perichondrium covering the tip and platelet-rich fibrin covering the dorsum. I also used platelet-rich plasma to improve the quality of the skin. And here we have the result after 14 months. She asked for a more natural profile and tip without any stigma produced by a rhinoplasty. Here is another secondary rhinoplasty with thin skin and some irregularities all over the nose. The main complaint was the basal and helicopter view. We used macrofat and rib perichondrium to prevent irregularities and improve the skin quality. And here we have the results after 7 months. And the last case is a primary rhinoplasty in thin skin, and we used microfat with platelet-rich fibrin covering it. She underwent a body liposuction, so we have the fat to use on it, and she had gone through bad healing and bad scar in other situations. It's only a month post-operative in these pictures, but you can have an idea of the results. She lives in another city, and she sent me pictures to follow up. This one is a 7 months after surgery, and we can see how good the healing is, and so are the scars. The dorsum is more even with no irregularities, at least until now. So that's what I have to say today. I appreciate the invitation, and I'm at your disposal for any further questions.
Thank you very much, Doctor, for your presentation.
Revolutionizing oral healthcare and the promise of terahertz radiation for oral oncological lesions. I got the idea when I was a first-year dental student at Damascus University in Syria, where I learned about radiations and the electromagnetic wave spectrum and so on. And I learned that X-rays are really bad for you. That's when I was a first-year student. But then when I completed my studies and now I'm about to graduate, and I think I'm the youngest of the speakers here, I've seen how we handle X-rays in the healthcare system, locally and internationally, that we don't care very much about or people are not fully aware of the downsides of X-rays and how dangerous they are. So since then, I set my mind to find a replacement for that, a safe and reliable replacement. And I think this will cause a revolution in the industry. First off, while oral cancer is rising globally, there are still many limitations because to treat oral cancers there are many ways to treat it, but most of them, if not all, are very invasive. And if it was surgery, radiation, lasers, and even the diagnostics methods are very dangerous, like the X-rays. They are still standard. Nobody has not using X-rays at all yet, but they are not very safe. So we are in this paper suggesting a new approach, which is terahertz waves. This imaging technique and treatment technique offers a non-ionizing and high contrast alternative to X-rays. So our goal, in short, is a safer, earlier detection of oral oncological lesions. For instance, the current limitations of X-rays are limited soft tissue contrast. X-rays are very good at imaging like bones and harder materials, but for soft tissues, people may use MRIs or other imaging techniques because X-rays are not very clear in these images. And cumulative ionizing exposure, so that equals cancer risk. So X-rays are very dangerous. The radiation affects the electrons of the atoms in our body, which causes some DNA modules and changes, which can elevate the cancer risk very high. Also, it's very high cost and it has bulky equipment. So it's not very portable, it's not very easy to handle, and it's very unsuitable for frequent follow-up or young patients. You can't expose a young patient to too much X-ray because when the body is little, it's the cancer risk is way higher. And as dentists, we are used to taking so many X-ray pictures to diagnose and to treat so many cases without noticing how one patient can get so much amount of radiation than it's advised to. So why all of that we discussed matters in oncology? First, early detection. Terahertz imaging offers early detection to detect early lesions and margins of non-invasively. Sometimes when we want to detect cancer and we want to actively early detect cancer, we use sometimes invasive ways. So it may get the cancer worse, not better. So we can use it in early detection non-invasively. Enhanced imaging. Terahertz are contrastable enough without dyes or radiation. Also, the biological basis, cancerous tissues have higher water content and different dissociation energy for their DNA. So the experimental design here is we found some oral lesions or oncological lesions, and we took some references from other papers about the energy and wavelength of the diode laser used on them to treat them. We converted this wavelength into the dissociation energy of each lesion so we can calculate the wavelength of and the energy of the terahertz wave that we could use to treat them instead of the diode laser or surgery or any other kind of radiation. After analysis, we found that the dissociation energies of many types of lesions like the periodontal cyst, the dentational cyst, root cysts, fibromas, all of them and more, their dissociation energies falls in the range of terahertz waves, so it gives us a high ability to treat them using terahertz radiation. But there are some limitations to using terahertz. For instance, the terahertz device is not very strong. It can't amplify the ray of terahertz by itself. So we have to use some amplification technologies like optical rectification, quantum cascade lasers, and photoconductive antennas. Those are some physical amplification technologies that we might incorporate with the technology of terahertz in medical fields. especially in the oncological field. Some key findings after we calculated and did the research we did is the first absorption peak of terahertz waves are at 0.8 terahertz and 1.4 terahertz. Cancerous lesions also show 30% higher absorption at 1.4 terahertz. Also, a 2 to 3 times more contrast improvement, and it outperforms the X-rays in tissue contrasts. So it's proven to be a much better replacement to X-rays, and we hope that this research will be the first step towards an X-ray free dental clinic someday. Then we can discuss the future of oral healthcare. From diagnostics, we can use the terahertz radiation because it can be high resolution label-free imaging to diagnose oral lesions and any other lesions that we can encounter in the dental practice. Also to treat the lesions by emerging use in non-ionizing therapy, because the terahertz waves are, unlike X-rays, are non-ionizing, non-invasive, and totally safe to use on the human body with no side effects. Clinical practice, we should integrate it in our routine and in dental diagnostics. And in future studies, we can study the AI integration for automatic lesion recognition. If you feed AI enough data on the lesion recognition using the terahertz radiation, you can develop program that can detect cancer from very early on when it's humanly impossible to detect without it. So the diagnostic and therapeutic value of our research is the first thing, the high resolution label-free imaging, which offers a clear visualization, contrast agents or dyes, without contrast agents or dyes, that can be really harmful while using X-rays, and real-time lesion detection, immediate identification, supports faster decision-making. So when you're in practice and you encounter a non-very ordinary lesion, you can right away use the terahertz radiation and get immediate real-time detection if this lesion is cancerous or not. Also, the non-ionizing thermal therapy, we can emerge the treatment options with the terahertz radiation to minimize the tissue damage. Also, which is a very plus point for terahertz, is the safe for frequent use feature. This enables regular monitoring without radiation risks. So you can take 100 photos, 100 images, you can monitor your patients using terahertz radiation, unlike X-rays, 100 times without feeling like you have to step out of the room to take the photo. Like we do with the X-rays, we tell the patients that it's completely safe. Then we step out of the room and wear a lead jacket to protect ourselves from the radiation, but still it can really be harmful and damaging without us even noticing it. So it's very underestimated, the dangers of X-rays. So for the safety and ethics in terahertz applications, first of all, as we said, it's not ionizing, so they do not damage DNA. That ensures that the patient is safe, and while treating dangerous lesions like the cancerous ones, especially oral oncological lesions, using X-rays on them may make the matters way worse and make the lesion progress way faster, while using terahertz waves offer a safe way to monitor and diagnose the lesion. Informed consent, it's essential for participants to consent on these trials, especially in clinical trials, which we have not done yet, but we are looking forward in future research to do clinical trials of the theoretical rules we are speaking about today. Regulatory compliance, we should, of course, adhere to the FDA and CE standards. And for now, the terahertz radiation is approved. There are still some researchers, but it's way safer than any other radiation. Data security, we should, of course, protect the patient digital privacy with secure digital scans. For the challenges we might face, for now, everything seems way too good to believe. Like there's an replacement for X-ray, which is safer, high resolution, way better, and even cheaper. It can be cheaper in the future. So why don't we use it today? Why we can't use it now? Because first of all, the main reason is because we need more funding for these kind of researchers to advance more, to apply this into a real device that we can apply to cases, do case studies, and advance way faster in this field, and maybe make the dream of the future without X-rays possible. Also, there are some technical issues with the terahertz radiation. First, the limited penetration depth. It only can penetrate only 1 to 2 millimeters in tissues, limiting the depth analysis. Also, the index matching media. We can use for that problem, we can use the gels to reduce reflection and enhance signal penetration in tissues because it can't be absorbed through water. So we need some kind of gels to further on the penetration of the radiation. Adaptive focusing optics, we can employ dynamic lenses to improve image resolution and focus within tissue. And we can combine terahertz with other non-invasive imaging technologies like infrared, ultrasound, or complementary depth and contrast data. When you can combine a technique of imaging or radiation with another, you get a wider spectrum that gives you more information about the state of the lesion you're examining without using X-rays or any invasive or surgical tools. The road ahead that we have now, first is the clinical validation ongoing via multi-center trials. We really need to do more research on the matter. This is just the first step towards an X-ray free future. So we need more clinical validation, more research, more funding, multi-central trials. Second, the development of miniaturized terahertz scanners for clinical use. There are being developed some portable terahertz scanners that can be used to detect dental decays or caries and small lesions, but it's still very new, so it can't replace the X-ray fully on yet. Also, we can integrate the AI to enable automatic lesion recognition, as we said before, with in addition to seamless integration into routine dental diagnostics. So my conclusions for today, I won't go into more details of physical aspects of it and the radiation aspects, but in short, terahertz offers non-ionizing high-contrast imaging with no DNA damage risk. Also, diagnostic potential, it enables precise detection and targeted therapy for oral lesions. It's a number one X-ray alternative in my point of view because it provides enhanced soft tissue contrast without harmful radiation exposure, especially while treating cancerous lesions. And it is, in my view, the future of dentistry. It supports personalized precision oral healthcare advancements. So we really need to focus on this field. It's very revolutionary. You can reach me through email and I can send you the research paper in full detail about the methods, the energies and the dissociation energies of each lesion and how we are anticipating to treat them using the terahertz radiation and how it is theoretically applicable. I want to have some acknowledgements for my university, Damascus University, in Syria, and the Saudi Journal of Oral Sciences. It's the journal that published my paper. And most important of this research, Dr. Marwan Rai, who had really key clinical insights and physical insights, who had a PhD in quantum physics. So if there's any questions, I welcome them. Once again, my name is Alice, and I'm a final dental year student. I will post my email in the chat for any further collaborations or any potential papers we might do in this field. Thank you, and I'm ready for any questions.
Thank you very much, Doctor, for your presentation. I hope
Fatigue is commonly described as a sense of burnout, a general lack of energy, or a reduced motivation to sustain a task. Fatigue is appreciated differently across various disciplines. There is no universally accepted or standardized definition of the term. Listening-related fatigue, one of the recent focus to the domain of the fatigue for audiology, is defined as a type of fatigue associated with the sustained application of the effort during listening tasks. The cognitive resources available for all processing needs are limited. In challenging communication environment, cognitive resources allocated to listening increase. This leaves fewer cognitive resources available for other processing needs. As a result of listening-related fatigue occurs. What do we mean by challenging listening environment? Listening in real-life situation is often made more difficult by various factors. Some common factors that create challenging listening condition include hearing loss or reverberation or background noise. This condition reduces the clarity of auditory input, forcing individual to allocate more cognitive resources to decode the message, leaving fewer resources available for higher level process like comprehension and memory. The literature states that listening-related fatigue can cause difficulties in concentration, attention, memory, and decision-making in individuals with hearing loss. Key advantages of evaluation listening-related fatigue: help manage patients with hearing loss, offer counseling and supports, detect challenging listening situations that routine audiological tests may miss, give advice when it's unclear whether treatment or rehabilitation is needed. Assist people who have trouble listening even if they don't have hearing loss. Create strategy to improve daily life and communication. In summary, assessing listening-related fatigue is critical for determining patient-centric management strategy. Listening-related fatigue can be assessed using behavioral, physiological, and subjective methods, each providing a different perspective on the listener's experiences. Behavioral measurements, example dual task parameters, being more related to listening effort are indirectly related to listening fatigue. Physiological measurement, for example, EEG or fMRI. Subjective measurements, for example, self-report scales. Vanderbilt Fatigue Scales differ from other fatigue scales in they focus especially on the listening-related fatigue. Unfortunately, standard clinical tests fail to capture the experiences of the listening-related fatigue in patients with hearing loss. As research on listening-related fatigue increases, the need for a specific measurement tool has become clearer. Hornsby et al. Developed the Vanderbilt Fatigue Scale for adults to fill this gap in the literature and to assess listening-related fatigue in adults with hearing loss or hearing impairment. Original language of VFSA 40 is English. This scale differs from other fatigue scales in the literature by focusing spatially only listening-related fatigue experiences. VFSA 40 is designed to address listening-related fatigue in four-dimensional or four subscale. These physical subscale, emotion subscale, social subscale, and cognitive subscale. VFSA 40 is very important as it is the first reliable and valid tool to evaluate listening-related fatigue. In this context, our aim was to translate and culturally adapt to VFSA 40 into Turkish while maintaining a semantic, conceptual, and cultural evolutions with the original English version. All procedures were conducted in accordance with whole guides. The translation and adaptation process of the VFSA 40 into Turkish was carried out in 6 steps. Step 1. Preparation. It was confirmed that the scale had been translated into Turkish before. The original scale developers and how the scale was used were identified. Necessary permission were obtained to use, translate, and adapt the scale. With the original scale developers, concept definition were created for each scale item before starting the translation processing. Step 2. Forward translation. Two dual language translators whose first language was the target language and who had experience in the target country culture were included in the team. Translators were informed about general health concept, the content of the scale, and translation requirements. Each translator worked independently. 2 independent translations were compared and merged into the one final version. Step 3, we call back translation. One new dual language translator who has experiences in the target culture and whose first language was the target language completed the back translate and produces a written record. The back translation was then reviewed by the original scale developers. Step 4, committee review. A multidisciplinary committee was formed, including a bilingual linguist, 2 translators, and 2 healthcare professionals. The committee reviewed the forward and back translations, including comments on the back translation provided by original scale developers, scale items, introductions, response options, and the translation report. Any revision to the scale were made based on the committee consensus and are described in the reconciliation report. Step 5, field testing. A small sample of the adults with hearing loss completed the Turkish version VFSA 40 to confirm the translated scale was culturally appropriate and usable by the target respondents. Step 6, Step 6, reviewing and finalizing the translation. The field test results showed that no further changes were needed. The translation process and the final Turkish version VFSA 40 were reviewed and approved by the original scale developers. All reports on the translation and adaptation process, related documents, a final Turkish version of the VFSA 40 were archived. In conclusion, the Turkish version of the Vanderbilt Fatigue Scale for adults demonstrates the strong conceptual, semantic, and cultural equivalence. Thank you for attention.
The conventional orthodontic surgical treatment for the correction of dental facial deformities take up the lengthy period of time preparing the patient orthodontically, which sometimes cause a temporary deterioration in the patient's appearance. This fact has set the stage for the development of the new treatment technique aimed at addressing these issues. Conventional orthodontic surgery treatment means for the correction of the deformed facial and comprise of the diagnostic and treatment plans. Pre-surgical orthodontic stage. The orthodontic surgery pairs orthodontic finish stage. This treatment method has also been tested by time. It has been used for decades and proved very effective. However, it's these limitations because when patients decide to undergo the treatment, they have to wait for almost a year on half of the surgery, and in most cases, patients see their facial appearance worse during this period. This is a paradox, as many patients who seek treatment expect to gain some aesthetic improvement. Also, the treatment produces a significant functional effect. Case report. This is a young man. He's deformed, had apparent in his childhood, class 3. Look the face, the profile, the front, profile, and the smile. Intraoral photos, you see the class 3, a large anterior open bite, a cross bite, a crowning, midline deviation, inverted curve of speed, and 2 planes occlusal. He put the orthodontic, the lines orthodontic only to the surgery. He don't orthodontic before. See, in this view, they put the orthodontic and they make surgical. After 30 days, the patient occlusion has better, okay, but without orthodontic stage. The X-rays after the surgery, and now the occlusion with 3 months before, after the surgical. These pictures you see before and after 3 months only, and the profile intraoral you see picture you see before and after only 3 months treatment. Profile face before and after, 3 for photograph before and after, and the conclusion. The anticipated benefits of orthodontic surgical treatment applying the principles reported in the dental literature to reverse treatment stages and anticipate the surgery. It provides some key advances such as fast improvement of both aesthetic and function. Everything, the temporary deterioration of facial aesthetic are found in many treatments of the dental facial deformities. This is reference, and so finish. Thank you.
Thank you for your excellent presentation, Dr. Thiago. Are there any questions from audience side?